Hi, everyone. My name is Solomé Tibabu, your host for the Going Digital Behavioral Health Tech Summit, and I'm so pleased to be joined with the nOCD team. So before we get started, why don't you guys introduce yourselves, please?
Sure, I'm Dr. Patrick McGrath. I'm a clinical psychologist. I've been treating OCD for 20 years, and I'm now head of clinical services for nOCD. In addition to that, I am also on the scientific and clinical advisory board for the International OCD Foundation and have trained therapists all over the world in OCD.
I'm Larry Trusky. I'm the Chief Operating Officer. I'm responsible for technology and operations. My background has always been in building products, whether it be for inpatient, outpatient, consumers. So I'm here to help build things.
My name is Stephen Smith. I'm the co-founder and CEO of nOCD. I'm really excited to be here today with not only you, but also with our team. And founded nOCD after my own personal experience going through this condition and realizing that, OCD is very effective, treatment for OCD is very effective clinically, but it's just not very accessible. And so if you can make OCD treatment more accessible, you could help a lot of people. And that's the nature for founding nOCD. And again, very excited to be here today.
Mm-hmm. Yeah, so speaking of that, why don't we just jump right in? What exactly is OCD?
So OCD is a mental health condition that affects approximately 1 in 40 people over the course of their lifetime. And it's a condition where people have these severe thoughts, images, or urges. And oftentimes those thoughts, images, and urges contradict someone's core values or personal beliefs. And to make those thoughts, images, and urges called obsessions go away, people do different actions called compulsions. And those actions can be mental actions, such as trying to mentally, push the thought out of your head or analyze the thought. It also can be physical actions, such as Google searching, such as checking a door, an appliance, and whatnot. So it's a condition that manifests with obsessions, intrusive thoughts, images, or urges that cause tremendous amounts of distress that oftentimes contradict somebody's core values and core character, and also actions that somebody does to try to make those intrusive thoughts, images, and urges go away. And those actions are called compulsions. And so the hallmark of OCD is somebody who has both obsessions and compulsions.
Mm-hmm. And, why is OCD so misunderstood? People have a lot of different misconceptions about it, and would love if you could shed light on that.
Well, one of the reasons we see it is that OCD's been the butt of jokes or movies and things in the future or in the past. And so we see it as it's checking doors or it's straightening things, which are very easy fodder for television and filming, right? What you don't see in OCD, though, is what most people with OCD have, which is intrusive thoughts are, did I just run someone over with my car and maybe I should drive around the block 20 times to see if there's a body? Or did I look at that person inappropriately, and did that mean that I wanted to harm them or do something sexually inappropriate with them or something like that? Or did I say a prayer wrong, and does that mean now I'm going to hell because of it? So those are really the kinds of OCD that we're seeing a great deal of. But because OCD's been so kind of marginalized to checking and cleaning, especially now with COVID, where we've heard people say, oh, I wish I had a little OCD right now. And we know that nobody would ever want something like that, that we want to make OCD more serious and show people what it truly is, that it's not funny and it's not a joke at all.
And I think to add to that too, it's often misunderstood because people, one, are very embarrassed of their obsessions. So those intrusive thoughts, images, and urges, like Patrick mentioned, they are very distressing, right? And they're embarrassing. They often contradict somebody's core character and values. And so the last thing they'd like to do is tell somebody about them, right? Like, for example, a mother with postpartum OCD, which affects approximately 3 to 5% of your mothers, there may have thoughts, what if I accidentally harm my child or harm my child purposely? And the last thing that mother will ever do is go and tell their primary care physician or tell their therapist. Why? Because it contradicts that mother's core values and character. That she really loves her child. She just has these horrifying fears, and because she spends so much time trying to push them out of her head, the fears grow stronger and stronger and stronger. And so it's a very misunderstood condition in that way. The other reason, though, is because, to Dr. McGrath's point, a lot of times providers will only think about OCD as just the checking or the hand washing. And so they may not even understand when somebody goes and says, I have these horrifying thoughts that just keep getting stuck in my head. I don't really know what to do. And that's actually personally my story, where I have OCD. I was misdiagnosed 5 times because of that same issue. I told my provider, my therapist, exactly what was going on. And they said, oh, you just have anxiety. Every time you have a thought, I want you to take a rubber band and snap it on your wrist. And then it got worse. And then I was told, okay, to make those thoughts go away, just go and drive away from your family. I think they're making the issue worse. And so I actually was recommended to go move away from my house. So I literally packed my bags, went away, went to rock bottom, developed severe depression. I had to leave school. I had to stop playing football. I was a college football player and was in a really bad place. And if it wasn't for just searching my symptoms online and finding others out there going through the same thing as me, I probably never would have been identified. And so that's a big issue. It's just, identification is so challenging because there's so much misunderstanding with OCD.
Mm-hmm. Yeah, thanks so much. That was so well articulated. And, that means a lot to a lot of people in the audience, but myself as well. Stephen, we've known each other for however many years through going to different OCD events. I personally have struggled with OCD. That is what got me into the space. And it's really challenging trying to explain something so inexplicable. So I think that was really, really great. But so talk a little bit about how is OCD treated?
Sure. Dr. McGrath.
Exposure, well, we utilize a therapy called exposure and response prevention therapy, which is really 2 parts. It's purposely exposing somebody to something that's uncomfortable, one of those unwanted thoughts or images or urges. But the key component is really something we call response prevention, which is not going and doing the safety behavior that you normally do. So if you have an intrusive thought and you would try to say, oh no, I don't really hate that person, I love that person. And that now becomes your compulsion. You have to say that every time, or else what if the thing happens that you're afraid of? What if they actually do get hurt because I thought something negative? We want people to sit with those negative thoughts or urges or images, and we want them to learn that they can handle them. They don't need to try to make them go away. And in fact, as Stephen had said, the more you try not to think of something, the more guaranteed you are to think of it. So I always use an example. If I say to the audience, don't think of a pink elephant right now. All right, just picture none in your head. Don't think of one at all. Everyone probably just thought of one. And if you try to make that thought go away, it's going to stick around. But if you allow it just to sit there, eventually a thought's going to pop in your head and like, wonder what I want for dinner tonight. Oh, wait, I'm supposed to be thinking of a pink elephant. So our brain's a bit of paradox. If you try not to think of something, you're going to think of it. But if you do the opposite and you sit with it, eventually it kind of fades away and other things come into your head.
Definitely. An ERP is a type of cognitive behavioral therapy. It's a very specialized form of treatment that requires training, right? So oftentimes therapists may say, I treat OCD, when reality is they don't have ERP specialty training. And so ERP is the gold standard. It's been proven in hundreds of randomized controlled trials to be very effective and the most effective treatment for OCD. So in order to get better, you oftentimes first need this treatment. And so it's a very big need today in the market, considering 1 in 40 people suffer with OCD, yet, ERP specialty networks really aren't abundant today, out there. And so that's a problem that we're solving, but, we'll get into that later, however. But, I think it's important to understand that first and foremost, to get better and to stay better with OCD, you need to get exposure and response prevention. And personally, I was able to get that. And that's when I made a huge turnaround. So kind of to go up, to talk more about the story, once I was at rock bottom, I found someone that specialized in exposure response prevention, because I was told that's the best treatment. The provider was completely out of network. She charged $300 out of pocket per session, had a 7-month wait list, right? And that was the only option to get better. So I had to sit in that wait list, had to find a way to make ends meet and pay for the treatment. I was fortunate enough to be able to do that. Got to that, therapist, saw her once a week. Between sessions, I was kind of by myself. So I was struggling a little bit, but more or less got through the treatment and got better, and was able to go back to school, regain my life, finish up my football career, and really just, get back to normal. And I think that's why it's so important to get ERP, is because if you can get it, you can really just completely transform your life if you have OCD.
Mm-hmm. Yeah, absolutely. I can certainly relate to that story of seeing however many therapists before you finally find one, and then thought, wow, this is what it should have been all along. And so, I suspect getting access to that kind of treatment is probably not very accessible still today.
Right. Right.
Which
Now it's getting much more accessible.
really,
Thank,
tell
the
us
hard
more.
work and Patrick here.
Yes, yeah, that leads me to my next question. What exactly is nOCD?
Sure. So nOCD provides online therapy for obsessive compulsive disorder. And here's how it works. People can come into our telehealth platform and they can do live face-to-face sessions with our licensed therapists. They're all licensed in exposure response prevention and they're trained exposure response prevention and they're trained also in OCD. And between sessions when therapists aren't around, the member can go and access different self-help tools and peer communities to have always on support. So its idea is, OCD is 24/7, right? It's a chronic condition. You need to be able to go and see these therapists that specialize in exposure response prevention. And you also need support between sessions, right? And so members get matched with one therapist. There's continuity of care throughout the whole treatment journey. And we're really excited because people are getting better. And then once they're better, they're staying better.
Mm-hmm. And what are the types of organizations you partner with to deliver that care?
Sure. So we partner with payers, so different health plans and managed behavioral health organizations. And we function as an OCD specialty telehealth provider. So we have a contract with the payer, and then we see their members and get them better.
Mm-hmm. And Stephen, you had mentioned something earlier that typical PCP might not recognize or identify patients accurately. So how do you identify patients?
Sure, it's a great question. So most patients don't surface in claims data. So if you look into a claims data set, payers that should have hundreds of thousands and sometimes millions of patients with OCD will see only several thousand or hundreds. It's just a massive, massive misidentification issue, just given the stigma surrounding OCD and the lack of awareness for it. So what we've done is we've identified most people online. So people will find us online, similarly how I was searching online for care because I was so embarrassed. That's what other people do as well. So they're willing to confide into Google, these intrusive thoughts that are so personal and so bothersome, and then seek care that way. And so we've grown very, very quickly online. We also grow through different partnerships. So we have different university partnerships, different digital health partnerships that help us spread awareness and reach people with OCD in need. And so there's a big opportunity to keep identifying people. And recently, even, we've been partnering with payers to identify people. So different payers who are starting to see the true size and cost of OCD on people's lives, they're now actually going and running awareness campaigns in their own population. And so we're really starting to see that improvement. And it's a huge testament to the innovative culture today surrounding the behavioral health community.
Mm-hmm. So Pat, I think you could talk about a 90-minute diagnostic, right?
Yeah. So in terms of specifically getting somebody to identify as OCD, we do a 90-minute diagnostic session. We do send people some assessment forms prior to session that they fill out because it gives us some ideas about what's going on with them. And then we also follow a structured interview while we're doing the diagnostic as well, too, so that we have very specific information that's research-based that tells us if a person actually meets the diagnosis or not.
Right. Right. So once to Patrick's point, once somebody comes into nOCD, first session is a comprehensive diagnostic assessment, and and then we take them through our treatment protocol, and our treatment protocol is evidence-based. We deliver ERP and live face-to-face video sessions, and then people between sessions use the nOCD platform for support. And we've been able to show consistently, we've been able to reduce the amount of sessions needed to get somebody better by about 50%. And that's OCD specific sessions. When people are seeing a generalist, they may spend up to a year or 2 years in treatment, just going to and getting psychotherapy sessions every week and not making progress. And in fact, actually getting worse, giving into their compulsions and becoming more at risk for developing substance use disorders, from becoming suicidal and whatnot. So we've been able to get in network and it quickly too, thanks to the hard work of Larry and the operations team, who have handled all of our credentialing and who've built up our network, sourced the providers, and also thanks to Patrick's effort in training those providers and ensuring we have ERP specialty care at the highest grade possible. Larry, do you want to talk more about the network and how you built it?
Yeah, sure. So we message providers, and the great thing about ERP is that people get better. So providers really do have a great experience. They see there's a lot of satisfaction as people are getting through the protocol. And so we recruit them, we put them through the training protocol that Dr. McGrath had put together. And then we get them live very quickly and seeing patients. And then we have a great support network in terms of them helping each other. If there's a certain set of conditions that they haven't seen before, it's easy for us with our network to get assistance and make sure that they have all the resources they need to help. So it's a really satisfying platform for the providers as well as the engagement with consumers.
Mm-hmm. Wow, fabulous. Not only growing on the drawing consumers in who are struggling with OCD, but really evolving and growing the provider side of things. And I just want to point out that piece about members finding you online, that makes a lot of sense to me. That, I was Googling all sorts of things, not even knowing what the condition was, but Dr. Google, Dr. MySpace, that was definitely my thing personally. And I think it wasn't until after I gave my TED talk is when my parents actually found out what the content of my OCD was all about. So I think that makes a lot of sense, and not surprising that that's very common.
The thing I would add is that with our community, we have so many new users coming on all the time. Probably the number one thing you hear from those users is that I thought I was alone, right? Mm-hmm. So they share a thought and they're like, wow, other people have this same issue, right? They didn't know, right? So that's heartwarming.
Yeah.
Absolutely.
And when you can then say, hey, we have a licensed therapist who specialize in treating exactly what you're going through, that's extremely powerful. And when we have technology that specializes in treating exactly what you're going through, that's extremely powerful. So we've been able to, really get people better because, they're getting access to such specialty care, right? And with a severe mental illness like OCD, that's crucial.
We can edit.
I had that turned off and then it came back on.
Anyway, okay, let's see. We'll find it. Okay, cool. So speaking of growing the provider network and just seeing the evolution of your company over the last several years, would love to hear a little bit more about just how nOCD has grown over the years.
Well, it's grown quite a bit. Thanks to the guidance of our investors and mentors and advisors, we've been able to become the largest online community in the world for OCD treatment. We're one of the fastest growing networks today in behavioral health. We are in a really great spot to uncover the secret illness, right? This is an illness that has plagued so many people, so many families, and nobody knows about it, right? It's so misunderstood. It's joked about, as Dr. McGrath mentioned. And so, we've transformed the way this condition is treated, and we've transformed the way people with OCD are identified. And so, at this point, we're now focused on fulfilling our mission, right? Our network is growing. We're in about 25 states right now. We want to get to 50 states. We want to reach hundreds of thousands of more members, right, that are suffering, and so they can join our community, learn they're not alone. And we want to help those people then get access to evidence-based treatment that is effective, that is affordable, and also very convenient. And so we've done that with our therapy protocol, and we're in a position now to do that at an even greater extent by just how fast we're growing. So, and I think and this is the thing too personally that has made a huge difference, is we've been told by pretty much everybody when we were starting that, hey, OCD isn't a problem, right? We don't have OCD in our population. Nobody suffers from it. It's really not even that severe. And we've been told that by a slew of people over the last several years. And the problem is it's just been hidden. It's not like and we've proven that that's the real fact. And so our growth has shown that, in fact, OCD is a huge issue, and it's causing people to become suicidal. It's causing people to develop substance use disorders. It's causing people to live in just extreme anxiety 24/7, but it's also very treatable. You just need to get access to specialty care. You need access to, therapists who specializes in exposure and response prevention, who also is convenient and affordable. So that's what we've proven. And we wouldn't be able to do it without our team, right? Our team has just been incredible. You have Larry, who joined early on, who, had really at the time no business to join us. He was He's been a healthcare veteran, helping found electronic prescribing, right? You have Dr. McGrath, who's one of the top OCD psychologists in the world, an incredible development team and an incredible marketing team that's helped us reach people in need. So there's more people even too that we haven't even talked about. So it's been an incredible journey, and we have bigger strides to make.
Mm-hmm. That's remarkable. Excited to see that continue to grow and evolve. And but I have to ask, with coronavirus, how has that impacted nOCD, what you do, business, everything?
Sure. Larry, what have you seen?
Well, certainly in terms of call volume, the volume has pretty much doubled the last couple months, right? Yeah. So we're seeing more and more demand. But in terms of why, Patrick, you could best answer that, right?
Well, what we're seeing too is that people now in rural areas who never had access to a specialist, and if they were going to have to drive actually to go see someone, now who can't leave their home and who would be suffering alone by them, now can just pick up a phone and make a call to our care team, get a free 15-minute call with that, and set up an assessment, and we're right there in their home with them. And I was on a session today with one of our therapists with a woman who spent a month pretty much in one room because she was so afraid of COVID. And now that therapist had her out on her balcony today, and she went outside for the first time today in 2 months. And I got to witness that. It was so amazing. And so that's the kind of stuff that we're seeing is these people who have been so afraid, so scared to even leave their home or their safe place. We're in their home, and we're now helping nudge them out of that to go and do that exposure and response prevention, actually start to get their life back.
Yeah, and I would say we were so prepared for this because of the teletherapy part of it, the whole face-to-face over video. We were in a perfect position for it, and it's helped a lot that a lot of states have said that we're going to do this, right? They've relaxed their laws in these states, whether it's on the Medicaid, Medicare side, and that's helped a lot.
Yeah, and I'll say too, taking even a step back, so COVID-19 has affected the OCD community in two specific ways. So first, you have people who have contamination fears or harm fears that fear that they'll catch COVID-19 themselves and become very sick or spread to an immunocompromised loved one. And what they'll do is they'll wash their hands until they bleed. They'll go and utilize testing resources, even though they're asymptomatic. So that causes a huge strain on the system. And they're doing so compulsively, and it's making themselves worse. The other group, though, are people who have the intrusive thoughts that are, religious in nature, sexual, violent, relationship-based. And those people are much more severe right now due to the stress of the overall situation. So they're forced to stay at home. They're quarantined. Their routines have been kind of changed. And as a result, their life's kind of out of whack. And so that stress causes their symptoms to become much more severe. And oftentimes, in those situations, they can't go see their therapist and drive to them. They have to go and, interact in a telehealth way. Well, we've been able to provide live video-based telehealth services given the platform that we've built, right? That's been serving people this year, right? So it's been a really strong way to help the community, and our team stepped up to the plate. So we're very excited for how we can continue helping the community during this time.
Mm-hmm. Wow, fantastic. As I've heard from other sessions so far, same thing with nOCD is a lot of learnings to try to pivot and scale up quickly to meet the demand. Would be great if you could talk a little bit more about learnings from building nOCD in general.
Sure. So I think to your point, we're scaling up quickly right now. I mean, we have a surge of demand, and to help the community at the scale which we want, we need to keep growing. We need to keep going and offering people with OCD treatment, right? So we're laser-like focused on that. The learnings that we've had though are several. I think first, in behavioral health, there's an identification crisis, right? People, will be suffering with something, and it'll take years for them to be identified with what they're going through and get treatment. That's evidence-based. And OCD is an example. 10 years to get identified and 7 more years to find evidence-based care, and that's the average today. So huge identification crisis. That can be mitigated though, right? If we can have a better way to identify what someone's going through, screen more appropriately, if we can have better content online, there's a lot of different things that we can do, better data science to identify people who've been misdiagnosed. There's quite a few things that we can do to solve that. The second is, I think behavioral health is best treated in a hub and spoke model. So you have a broad solution at the top of the funnel that can connect people to specialized networks and technologies that can address needs in a really personalized way, right? So in that solution, you have people getting care that they need that's personal to them, while also you mitigate vendor fatigue at the top of the funnel, right? So I think that's the second learning. And I think the third learning is to really treat some of these conditions well, you need a balance of tech and touch. You don't just need touch, you don't just need tech, you need a balance. And you need to be able to see a therapist and in between sessions get support. Well, who's doing the work in that setting, right? I think at some points you have the therapist doing the heavy lifting. At other points you have the technology. And within that patient journey, you may have more touch in certain areas, less touch in others. And with certain conditions, it may be even different. For lower acuity conditions, you may just need technology and an occasional therapy session. For higher acuity conditions like OCD, you may need to front load the therapy sessions and then step down a technology as relapse prevention support, right? So that's the world in which we now live. And to really manage the population, we're going to need to be able to use a combination of tech and touch. So those are learnings on my end. How about any of you all?
Yeah, it's cliche, but meet the consumer where they are in their journey, right? So that whole balance, just offer a scale of those and meet them where they are.
Yeah. And I just say, as a clinician who worked at a hospital for 20 years, it's been rather incredible to learn about this whole other world that I didn't even know existed until several months ago. I mean, I've worked so much with nOCD and known it from the app-based thing, but to have been thrust into the world of teletherapy, as Larry said, we were ahead of the game and had this ready to go. And watching other people who had no kind of preparation for this and how much that of a struggle that's been, it's been a really incredible journey to learn new ways to provide therapy to people. And I think it's going to change the way we do therapy going forward forever. There's no going back to just the way that we did it. That's not going to work anymore. Now we have new ways to do it, and we can reach more people, and more people I think are going to get better because of it.
Mm-hmm. Definitely.
Absolutely. Well, this is so inspiring. And Stephen, as I've told you many times before, I only wish this was available when I needed it most. And I'm just so pleased to see how things are developing and how much you're helping so many people right now. And we're out of time, but I hope attendees, if you want to follow up with the team, there'll be information available and you can ask more questions. But Stephen, Larry, Dr. McGrath, thank you so much for your time.
Yeah, thank you, Salome.
Thank you. Thanks, Salome.
All right.